Hi, thank you for your excellent presentation, both guys. I have one question. I work in a pretty busy center in Houston, Texas, and we get all these people that, you know, they lie flighted to us with big MIs and post-cardiac arrest, and we're very aggressive with hemodynamic support, so we either put them on ECMO or I put them on tandem, and then we revascularize them, and then they stay in the hospital for a couple of weeks, and we're all happy that they walk home. And then I'm the same guy, though, that sees them like 2 months later, you know, in the office, and you know, this guy post-MI, now his LV is a little bit dilated, and now he has this like moderate MR without actual valve pathology. Okay, so my question is, I know that his MR is not going to get better. I mean, I give him diuretics.
You just can't increase the ACE inhibitor?
Well, okay, fine. Okay, right, exactly. That's like total non-invasive, you know, answer. So, you know, what do I do about this guy? I mean, if I tell, you know, Tom Wynn, can you minimally repair? He's going to repair it for me. If I told Richard Smalling, are you going to put a mitral clip? I guess he will. But, you know, what's the right answer here? Is it dependent on the STS score only? Are there any other things that we should
What's
consider?
the right answer for somebody with moderate MR?
Right, moderate to severe MR. I mean, I see this guy that I mean, I know that this is going to progress.
You know, we certainly don't have enough data to give the answer, particularly in terms of mitral clip. Obviously, we know that's an off-label use, or you get them into COAP. Once we have that data, I think it'll enlighten us a lot more. If they have severe MR and they're symptomatic, we know that's ischemic MR. You know, it's a class 2B indication, so you have to look at your own results, and if the results are good at your institution, I think it's reasonable, realizing that we probably won't affect that patient's ultimate survival, but we probably could help their symptoms. So they would need to be symptomatic. I think that's the other component before you're going to embark on any therapy, you know, specifically surgery. In terms of repairing versus replacing, obviously there's some guidance in terms of criteria based on basal dyskinesia and tenting and LV dimension. You know, there's lots of things that's been written, but that's another thing. Certainly look at as a team. I like what Paul said. I mean, this is a team approach, and I don't think surgeons incorporate their team as much, the heart team as much. We do it a lot on certainly when we're evaluating for transcatheter disease, but we don't do enough of the other direction. Hey, let's look at this, and what do we think about the likelihood of acute repair, and more importantly, long-term repair, and should we just go ahead and replace it? And that way, it's, you know, the concept of replacing the valves of sin, it's a little more absolved because Paul said it was okay to do.
But what really is wrong with replacement, a coil sparing replacement? I guess maybe 10 years ago, it was like, oh, the bioprosthetic's not going to last, and it's mechanical, and you're committing them to lifelong warfare and all those issues. But nowadays, figuring that 10 or 15 years from now, there will be valve applications. Why is it so bad?
I think at this point for FMR, it's becoming certainly a lot more accepted. We know the guideline. We know the ACC guidelines have changed that accept that as a reasonable strategy is how it's worded, and more surgeons are doing it. I still think that there are some unknowns. You know, we do see some patients that also have issues with their bioprosthetic valve, with thrombosis, with embolization, with endocarditis. We had a patient not too long ago, not the best protoplasm, and young lady, 55-year-old uninsured lady, and her valve has already had issues. I mean, so yet I knew at that point, I said I never want to go back in, and now I'm faced with I may have to go back in because she stopped taking her anticoagulation and, you know, is having some issues with thrombosis.
Every time I listen to a talk about mitral valve repair, it's fascinating the tools that is available, you know, for surgical repair. And this is more like a philosophical question. I mean, as we are transitioning to transcatheter repair, you know, whether it's with LV remodeling or coronary sinus devices or percutaneous ring or mitral clip, and how do you envision in all those devices? And I was involved. You alluded to the self-valvular apparatus remodeling, MyoCore, or whatever. How do you envision that transition where we have to combine tools, but now the tools are in different hands and in different trials? And do you think this will impede our ability to treat functional MR percutaneously by combining all those various tools that you have access to in the surgical repair?
So it's a limitation, as I mentioned on the last talk, just because we'd love to combine them, but certainly true comparative effectiveness trials are going to be challenging. I think there's going to be a lot of experience, a lot of different approaches, and we'll have to either use registries or other experiences to say these are the combinations that might work. I think it's going to get very complex and all over the place in terms of what different centers are doing. We'll have to see what ends up working. I do think that the more of these devices that are out there and more strategies, the more complex it's going to be, and it's not going to end up being one particular approach for every patient. And that's where the preoperative imaging to help us predict what might be best is going to be really important. Whether it's, maybe we'll have to start looking at CT to really look at some of the other parameters potentially, or other imaging modalities beyond the sophisticated echo that we're getting. And echo is even getting a lot better and better. I mean, we're understanding things now that we didn't at Everest, and that's also true. I mean, the whole ERO guidelines have also changed in the last 2-3 years. So we're understanding it a lot better. I wish I had a better answer.
As my former colleague Thor Sant said from surgery, he said, if you can fix it with a catheter, just fix it with a catheter. But it's more complex than that. We have to be as good as the surgeons. And until we are,
but we don't, because they're different patients. I mean, so a lot of these patients are sick.
Yeah, I get. Yeah, but until if we're able to treat patients who are not on death's door, and if you look at COAP, that trial is focused on patients who the horse has already left the barn decades ago. I mean, these are the sickest of the sick. If we're going to move towards patients besides those, we have to be just as good as the surgeons. Because, look, his operative mortality is 1%. How can I beat that? So the only way I can even get close to that is if my efficacy is comparable. And so that's where we have to change our thinking. And I think for transcatheter therapies, we have to think like that. It's great to prove feasibility in that we can get MR reduction 50-60%. That's great for feasibility. But for widespread acceptance, we'll never come close to surgeons unless our efficacy gets better.
But our when you talk about when we repair, our recurrence is also the same. So this is the pathophysiology of the disease, and we need to understand the disease differently.
A co-op's not going to answer that question.
It's not.
People, like you said, these people were long gone already.
No,
what to do with a patient who could go to both.
Yeah. Very hard.
I don't know that.
Yeah.
Very hard.
And I don't think we're there yet with the transcatheter technology.
Yeah, and then the question is, I mean, do we have a transcatheter trial? We're talking transcatheter only trial, so clip versus replacement, ultimately.
Yeah, those are hard trials.
Yeah, I agree. And there's going to be a lot of patient selection involved. Yes, sir.
If we have a patient like a multivascular disease, ejection rate 30%, left ventricle dilated, and moderate regurgitation, going for bypass surgery, what is the recommendation for mitral handling? Yeah,
so I didn't talk a lot about the NIH CTSN trial that we did in the United States, looking at moderate MR in the setting of a CABG. So patients, it was, I think, 400 patients were randomized to CABG alone, and half of those were randomized to CABG plus a mitral ring. And what we essentially showed is we can decrease the number of patients that have recurrent or MR, at least moderate. Not many of those patients went on to severe MR. But what we did find is that in terms of the primary endpoint, again, of ventricular index, it was no different. And at the same time, there's also some signal for more neurologic events when you start adding a mitral operation versus a CABG alone. And so the guidelines right now suggest that there's no need to add a repair. My own practice is a couple things. One is if we're revascularizing the posterolateral wall, then I feel better about leaving the mitral alone. But if we're not, if that's already scarred or there's no circ target, then I worry that their MR may not improve as much. And then there is some data from post hoc data to suggest that might be the case from the CTSN trial. The second is if their main symptom is heart failure, I'm a little more concerned, and not as much angina, then I'm more likely to consider putting a ring on that as well.
right, thanks
Thank you.
everyone. Thanks for coming.